Yes, sir.
Yeah.
Yes, sir.
Yes. Okay. So this time it is very simple. You just give the ID number.
Yes. Yes, yes.
So thank you very much once again for calling me within a month. I remember
It's our
just last
pleasure.
month, 20th, I was with you.
Yes,
All.
sir.
So thanks to you for accepting the invitation and sparing your time, sir.
Yeah, it's always a pleasure for me to share the knowledge with everybody and learn from everybody.
Thank you so much for that, sir.
I'll just come in a minute.
Yes. डॉक्टर शिखा
हाँ मैम.
डॉक्टर अंजलि मैडम रास्ते में हैं.
अच्छा अच्छा मैम.
शायद वो अभी जल्दी से ज्वाइन नहीं कर पाएंगी. अपने को
ओके
अभी
मैम.
है थोड़ा 5-1 मिनट तो अपन रुक जाते हैं. अगर आ जाएंगे वो तो ठीक है, नहीं तो उन्होंने बोला आप लोग मीटिंग स्टार्ट कर देना, तो
हाँ
फिर
हाँ
आप भी डॉक्टर पाई का
हाँ हाँ
इंट्रोडक्शन दे देना.
ठीक है मैम.
बोला कि चेयरपर्सन मैडम ज्वाइन
तो
करना
मैम
है थोड़ा
इंट्रोड्यूस
सा.
डॉक्टर अंजलि को कैसे करेंगे अपन? मैम तो ज्वाइन नहीं करेंगे, तो पहले अपने स्पीकर को कर देंगे.
हाँ, जब करेंगी ना मैडम ज्वाइन, और भले लेक्चर के बाद में मैडम को शॉर्ट इंट्रोड्यूस कर देना कि मैडम ने अभी लेट ज्वाइन किया है, शी इज चेयरपर्सन.
ठीक है.
मैडम आपको एक कंक्लूडिंग रिमार्क्स देना चाहे तो, क्योंकि ज्वाइन तो करेंगी पर बोले मुझे लगेंगे 10-15 मिनट.
ठीक ठीक मैम. ठीक 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 मैम. जस्ट 2 मिनट्स.
मैम मेरी स्क्रीन दिख रही है क्या?
हाँ दिख रही है।
सर का सीबी?
हाँ दिख रहा है।
हाँ दिख रहा है मैम, दिख रहा है।
ठीक है, इसमें से रीड कर सकते थे।
We are live now. Good to go, sir.
Okay.
Over to you, doctor.
Yes. Good evening, everyone. Ma'am, should I start?
We can wait for another 4-5 minutes. Madam may join with us. Or then we'll...
Okay, okay, ma'am. Okay, ma'am.
Dr. Nihal?
Yes.
Yeah, we can start, sir. Please.
Yes, we can start, but we want to wait for a few minutes for our chairperson, ma'am, to join.
But she's traveling and will be reaching within few minutes.
So, ma'am, you want to wait, right?
Pardon Neha?
Ma'am, wait करें ना?
4-5 मिनट वो बोली मैं ज्वाइन कर ही रही हूँ कर लेंगे तो ठीक है You can start. मैडम का मैसेज आया कि उनको थोड़ा और देर लगेगी.
Okay, ma'am. हाँ, ma'am. So we'll start now?
Yeah.
Okay, ma'am. Yes, ma'am. Good evening, everyone. I, Dr. Shikha Khandelwal, on behalf of Ratlam Ops and Gynae Society, would like to welcome you all in this webinar of gestational trophoblastic disease, and can assure you it will be a brainstorming event and feast to our minds. But before that, I would like to invite Dr. Mainisha Maheshwari ma'am, who is Chief Gynecologist, Maheshwari Hospital, and President, Ratlam Ops and Gynae Society, for the welcome speech. Ma'am is not only a leading practitioner of Ratlam, but also a kind-hearted doctor in whose leadership ROGS is achieving new heights. Please, ma'am, I request you to please open the session by welcoming our guests and speaker.
Thank you, Dr. Shikha. Good evening, everyone. We members of Ratlam Society are fortunate to welcome Dr. Muralidhar Pai sir from Manipal, who is a great orator and teacher. I welcome our chairperson. She is late. She will be joining few minutes later. Dr. Anjali Kanhare ma'am, President, Bhopal Society. I also welcome seniors, colleagues of Ratlam Society and other participants in today's webinar on gestational trophoblastic disease, its etiopathogenesis and management. Without wasting much time, I hand over the dais again to Dr. Shikha a dynamic infertility specialist and obstetrician of Ratlam, to carry the meeting forward.
Thank you, ma'am. Thank you so much, ma'am. To all attendees, I would like to introduce to you our session chairperson, Dr. Anjali Kanhare. But for some unwanted reasons, she's not with us, and she'll be joining us soon. But so, in the meantime, I would like to introduce you to our speaker, who actually doesn't need any introduction. So our speaker, Dr. Muralidhar V. Pai, is Professor and Head Department of Obs and Gynae, KMC Manipal. He's also Chairman, Medical Education Committee, South Asia Federation of Obs and Gynae. He's member and of Governing Council of Indian College of Obs and Gynae. He's Associate Member of RCOG UK. He's a prolific and popular speaker at national and international forums with 482 lectures to date. He has 174 publications in national and international journals. He's author of Holland and Bruce Manual of Obstetrics, 4th edition, and Obstetrics and Gynecology, 1st edition, Elsevier. He has won several awards, including Best Outgoing MD Candidate, Best Teacher, 8 times, Best Teaching Material, 3 times, and Foxy Korean National Award for Best Research, both junior and senior. Wow, sir. He has 34 years of teaching experience, 30 years of experience as MBBS, MS, MCH, and DNB, FNB examiner at national and international universities. It is, we are really fortunate, sir, that we can hear you, sir. Sir, I invite you to please start the session, sir, and
Thank you.
give us your valuable words, sir.
Yeah. Thank you, Dr. Shika, for the introduction. And I would like to thank Dr. Manisha ma'am and Dr. Anita ma'am and Dr. Neha for inviting me second time in less than 1 month. I remember giving a lecture last month, January 20th, on diabetes, and they have invited me again. This shows their love for me, and I would love to come to Ratlam Ki Galiya. I just saw Ratlam in Jab We Met movie, but I had to see it in live. So I really wish I would be able to come sometime. So without wasting much time, I would like to share my PPT and start my talk. Yeah. Yeah. So today's topic is one of my favorite topics, and I was fortunate to get my first international fellowship, UICC fellowship, to visit Charing Cross Hospital, London, where Dr. Bagshaw was doing an enormous work in this particular area. I was fortunate to meet both Professor Bagshaw, whose Bagshaw regime, Bagshaw scoring was very popular. And I also was fortunate to meet Professor Newlands and work under them in Charing Cross Hospital, London, in this particular area. So I also published a paper where it was very clear that the second DNC is not required. That was the paper I worked on when I was in London. And it is always a favorite topic of mine. And I thank once again for giving me this topic. Hydatidiform mole is actually a disease which has been there in BC, before Christ. It was first described by Hippocrates around 400 BC, and he called it dropsy of the uterus. I really don't know why he called it dropsy. The classification is very important for all of us to understand, because it's then we realize how to treat these things differently. When we say gestational trophoblastic disease, that is GTD, all problems are included. What do I mean by all problems? Pre-malignant, partial or complete hydatidiform mole, which is called PHM or CHM. Then invasive mole, choriocarcinoma, placental site trophoblastic tumor, epithelioid trophoblastic tumor, and atypical placental site nodule. All are included when we say gestational trophoblastic disease. But the last 5 are malignant variety, whether locally malignant or metastatically malignant. They are together called gestational trophoblastic neoplasia. This is very important for postgraduates from the point of writing in the exams, as well as for a practitioner from the point of dealing with them. The risk of gestational trophoblastic neoplasia, the malignant variety, increases from partial mole to complete mole. When it is partial mole, the risk is only 0.5 to 5%. It jumps to 15 to 20% when it is a complete mole. But we must remember that GTN can arise after any pregnancy, including a normal pregnancy. It need not be always complete HMO. The risk of choriocarcinoma among the GTN, choriocarcinoma is the most dreaded one. The risk of that after complete mole is up to 15%, whereas after invasive mole, it is only 3%. Epidemiologically, as all of us know, it is common in Oriental countries, mostly in the eastern part of the world. Highest incidence being in Philippines, though Japan also we used to say, it is 1 in 80 pregnancies. Whereas in India, it decreases rather, it is 1 in 400. I have just rounded the figures for easy remembering. And it is lowest in Europe, 1 in 800. Actually, it is 752. So I made it easy to remember 80, 400, and 800 pregnancies. So it is actually rare, but surprisingly, most of the research and the regimes are developed in the Europe. That's what I was working in Charing Cross Hospital. There, Bagshaw developed the Bagshaw scoring system, Bagshaw regimes, and all those things. The risk factors are obviously extremes of age. Why I'm saying obviously, because when I talk about etiopathogenesis, you will realize it is something to do with the abnormality in the gamete, especially the female gamete. So extremes of age less than 15 years and more than 45 years is a very important risk factor. However, this is not for partial mole, it is only for complete mole. Nulliparous are also at more risk, probably because of the same reason, the gamete abnormality. Previous mole rises from 1:1000 to 1:776 and 1:7 in subsequent pregnancies. That means a single mole, the recurrence rate is less. But if a person has 2 moles, the recurrence rate increases, and that's how it keeps on increasing with 3 and 4 moles. We had a case of 6 molar pregnancies in Manipal when I was a junior staff here. But the positive side or good side of it is 98% of subsequent pregnancies will be normal. This is what we have to highlight. So we have to counsel the patient saying that just because she had 1 H mole, she need not have it again. Blood group A or AB are at slightly higher risk than those with type B or O. Anyway, luckily, these A and AB are rare blood groups. Taking COC pills also increases the risk, but there is nothing to worry much because a risk is lower for short use. Most of them use it for a shorter period, up to 1 year or maybe maximum 2. It is higher for a longer use. But the risk is still so low that it doesn't outweigh the benefits. So no need to worry about taking COC pills. Dietary deficiency of beta carotene and animal fat has been blamed. Probably that's why in the East, where the rice eaters, they thought the incidence is more. Smoking and drinking alcohol almost for all diseases are risk factors. Having multiple sexual partners, again, something to do with the dispermy and gamete abnormalities. I'm going to explain that soon. Low socioeconomic status goes well with the other problems of dietary deficiencies, smoking, and alcohol. So now I come to the pathogenesis of complete mole. As I said, it is due to androgenesis. What do you mean by androgenesis? An empty ovum where the maternal chromosome is inactivated. The nucleus of that ovum is inactivated. This empty ovum is fertilized by sperms. If it is homozygous, which is 85% of the time, it could be either a single sperm of 23 gets duplicated, or it could be two sperms, 23X and 23X, which is called dispermy. As a result, you will have 36XX. But the most important thing to realize here is both are from father. It is paternal chromosomes. So this is the most important cause of the complete cause. Can somebody switch all the audio off? Somebody is having traffic, is in the traffic, and that phone is audio for everybody except speaker.
Excuse me. Other persons, kindly mute yourself.
The host can mute all. Host can mute all. Okay, thank you very much. So it is androgenesis. That means the zygote has got both the sex chromosomes coming from the father rather than one coming from father and another coming from mother. The other possibility is androgenesis but heterozygous, which occurs in 15% of the cases. Again, the same empty ovum is fertilized by two sperms, but one of them is Y, another one is X. So again, it is a paternal dispermy, but here it is heterozygous. Again, paternal chromosome only. But when it comes to partial mole, it is not the inactivated or anucleus egg. The egg contains 23X, but it is fertilized by two sperms, X, X or XY. Usually it is X and Y. So what happens here? There will be a triploidy of 69 XXY. Now, one X is from the mother, but other X is from the father. Y obviously is from the father. So this is the partial mole. Triploidy, where both maternal and paternal chromosomes are present. What is the clinical course? As all of us know, the commonest symptom of the patient is vaginal bleeding or watery brown discharge. 84 to 97% of the patients will have this. In fact, some patients may also complain of passing the vesicle-like structures. If that history is given, then the diagnosis is very, very obvious. Theca lutein cysts can be seen in 50% of the patients when you do ultrasound, but not 100%. Excessive uterine size, we always tell it as a typical finding and teach it to all undergraduates, but it is present only in 28% of the cases. Early onset of preeclampsia drops down to 27%. Hyperemesis gravidarum, which again we highlight as one of the symptoms or one of the diagnostic features of hereditary mole, is present only in 8% of the cases. Hyperthyroidism is also in 7%. Why is this? That is because of early diagnosis and management of the cases. In the olden days, we used to see this, that is early onset preeclampsia, hyperemesis gravidarum and hyperthyroidism. But nowadays, thanks to ultrasound, we diagnose H-mole very early and we deal with very efficiently. Trophoblastic embolization is seen in 2% of the cases, and symptoms of missed abortion is mainly seen in partial mole. The diagnosis is very, very easy and obvious. the HCG is elevated, but then HCG is also elevated in twins. So ultrasound clinches the diagnosis. In the past, when the resolution was not very good, we used to call snowstorm appearance. But now, with high resolution ultrasound, we can see honeycomb pattern. Thick agglutinin cysts, as I told earlier, will be seen in 50% of the patients. They are usually bilateral, the big ones. In partial mole, you can see non-viable gestation, as some sort of a fetal formation will be there, but mainly enlarged hydropic placenta. You can see here the fetus is in the view for a short period, and rest of it is only hydropic placenta. So this is the partial mole. We have had a case of tubal H mole also. In fact, that patient later developed persistent trophoblastic disease also. Here, a solid heterogeneous adnexal mass which is separate from the ovary can be seen, and the diagnosis is essentially given by the pathologist, not by the obstetrician. You can see tubal headed form mole as a variant of ectopic pregnancy. Invasive mole is a locally malignant condition of after the evacuation of vesicular mole. How can you diagnose that? It's a distension of uterine cavity with echogenic material with cystic spaces. And if you use Doppler, there will be a mosaic pattern on the Doppler, and there are areas of ill-defined myometria. The arrows are showing, the thin arrows are showing towards the ill-defined myometria. The choriocarcinoma is unmistakable by ultrasound. You can see heterogeneous mass with diffuse cystic pattern and increased vascularity on Doppler. Histopathology is not necessary to diagnose choriocarcinoma. High levels of HCG is enough, but if you send the specimen, then you will see absence of chorionic villi, presence of abnormal intermediate and cytotrophoblast rimmed with syncytiotrophoblasts with areas of necrosis and hemorrhage. Having understood the etiopathogenesis, the pathology, and the symptomatology of H mole and the GTN, let us now take up the management, which is very, very important. Now, as far as the management of H mole, whether it is complete or partial, there is absolutely no doubt that this pregnancy is non-viable. This cannot be allowed to continue. In fact, nowadays, if somebody comes across H mole after first trimester, it's almost like a crime. Or whether the crime from the doctor's side for not diagnosing it, or crime from the patient side for not going to a physician early. Suction evacuation as soon as you diagnose is the management of vesicular mole. There's no doubt, no two words about it. Now, how do you do the suction? You can use a mechanical suction, but better would be an electrical suction. And always the suction cannula is plastic cannula. Usually 12 to 14 size should be good enough unless you are dealing with a uterus which is measuring more than 16 to 18 week size. As far as the dilatation is concerned, there is no need to do any mechanical dilatation because cervix is usually patulous. If at all, some people believe in introducing 200 micrograms of misoprostol on the day or early morning of the evacuation, but that is also usually not required. As far as oxytocin drip is concerned, there is slight controversy. Many believe in starting up an oxytocin drip as soon as you start evacuation, but the problem with that is there can be embolization due to contraction of the uterus as you are evacuating. However, after evacuation, oxytocin drip is definitely going to control the bleeding by making the uterus contract well. So oxytocin drip post-evacuation is definitely required, but during evacuation is slightly controversial. There is no need to do curettage either at the time of evacuation or definitely not needed after 1 week. As I told you in the beginning of the talk, This is the study I did when I was in London, which said there is absolutely no need to repeat the curettage after 1 week. Unless, of course, if you think that very selected cases where the primary evacuation was totally incomplete and patient has been having severe bleeding, only those such select cases we may consider. But nowadays, most of the evacuation goes on under the ultrasound guidance, and most of us at the end of evacuation will do an ultrasound to see whether the evacuation is complete. So there is absolutely no role for doing a curettage either at the time of evacuation or at the time after 1 week of the evacuation. In fact, there is no need to curate the uterus dry. That can be actually sometimes dangerous. You can cause perforation, you can cause infection and things like that. Blood products should be obviously kept ready, especially if you are dealing with high volume H mole. And all patients with Rh negative blood group, if the husband is positive, they must receive anti-D because trophoblasts themselves can express the antigen. There is no need of a fetus there. So anti-D is a must. Probably in the first trimester, 100 micrograms is more than enough. But if it is not available, you can still give 350 micrograms. Medical induction of abortion and hysterectomy are not recommended for molar evacuation. This I want. They say, can you manage with the tablets alone? This is not advisable because, first of all, there will be incomplete evacuation. And secondly, the severe contractions that are caused by misoprostol, that too, we give high doses of misoprostol, 800 micrograms, can make the vesicles go embolic. Management of H mole. These methods increase the maternal morbidity and the development of post-molar GTN requiring chemotherapy. Now, with regards to hysterectomy, we recently had a big debate in the class whether to do hysterectomy or not. Then I really searched into the literature. This International Journal of Gynecological Obstetrics 2018, they mention about hysterectomy is as an alternative to suction curettage if childbearing is complete. However, we do not agree with this straight away. Hysterectomy is not an answer. Ladies, even in older ladies, hysterectomy is probably not required unless if you have met with a perforation, if there has been a severe bleeding, and to control that bleeding, probably you may require hysterectomy. Post-evacuation follow-up is the most important part of the management, and this is one of the most common questions asked in both undergraduate and postgraduate exams. So you have to do weekly HCG measurement until it becomes normal for 3 consecutive weeks. Even if it becomes normal, you cannot stop it. It should be normal for 3 consecutive weeks. And by experience, all of us know that normally the test becomes negative in 6 to 8 weeks. Thereafter, you can do monthly for 6 months. And if the patient wishes to become pregnant after that, after a hydatiform mole, if the HCG has been negative for 6 months, you can stop the follow-up and she can become pregnant. But if she doesn't want to become pregnant, then you must continue the follow-up once in 2 months for another 6 months. So maximum of 1 year follow-up is more than enough for hydatiform mole. Probably 2-year follow-up is required only if it is a case of GTN post-chemotherapy. So if HCG becomes normal, as I said earlier, follow-up may be discontinued and pregnancy can be allowed even. So when you follow up the beta HCG, you can see the 10-fold decrease per week, and that is the normal beta HCG regression curve. 100,000 becomes 10,000, 10,000 becomes 1,000, 1,000 becomes 100, and it becomes 10, and drastically it comes down. This is the ideal regression curve. Any deviation from here will help us in diagnosing the GTN. I'll talk more about that in a short while. Suppose somebody becomes pregnant during follow-up. Ideally, we must ask them to avoid pregnancy. You can advise OC pills, you can advise injectables, progesterone-only injectables. You can also advise barrier contraceptives. But by chance they become pregnant, termination is not indicated if there is accidental pregnancy during surveillance after HCG level has returned to normal. In fact, pregnancy won't cause a problem. Pregnancy only will confuse the issue if the HCG was not normal before she became pregnant. That is the idea, not that pregnancy will increase the chance of GTN. So once the HCG has come normal, but still she is under surveillance and accidentally she becomes pregnant, it is not an indication for MTP. Data now shows that it is safe to recommend oral contraceptive pills, as I said already. Another controversial area is prophylactic chemotherapy after HMOL evacuation. All of us know when it is GTN, definitely chemotherapy is required. But if it is a non-malignant, either partial mole or a complete mole, do we need to give prophylactic chemotherapy? The answer is no. It is no longer recommended as this exposes 80% to unnecessary chemotherapy. As I told you in the beginning, the chance of GTN is hardly 10 to 20% after the complete mole. But you can always catch them early during your follow-up and then risk them and then give proper chemotherapy rather than prophylactic chemotherapy. As I said, the prophylactic chemotherapy at best is controversial. It may be considered in high-risk women. Who are these high-risk women? Where HCG is over 1 lakh international units per liter before emptying the mole, or HCG regression curve is not progressively declining, or it is plateauing after initial decline. When hormonal follow-up is unreliable or unavailable, suppose the patient is not coming for a proper follow-up, you think like that, then maybe you can give a prophylactic chemotherapy. Uterus is obviously larger than size of amenorrhea is another indication, and luteinizing cysts more than 6 centimeters and multiple cysts, which may probably need prophylactic chemotherapy. One caution here, please don't try to aspirate any theca lutein cyst. Don't do any surgeries. Don't do laparoscopy. Don't do vaginal aspiration of the cyst. The cysts will regress on their own the moment HCG comes down to normal. Only if the HCG is not coming down to normal can you consider prophylactic chemotherapy. I hope I am very clear in this. Now, risk of recurrence of HMOL. As I said, it is very, very low. 98% will be having normal pregnancy after 1 molar pregnancy. But if there are 2 consecutive molar pregnancies, then the risk increases steadily. It is maybe because of mutations in NLRP7 and KHD C3L. That's why they may have recurrent molar pregnancy. Now, I turn to the malignant variety, that is GTN. As I said, incidence of GTN after molar pregnancies up to 50%. But I would rather put it this way, it's only 50%. That means GTN can occur after an abortion, normal pregnancy abortion, ectopic pregnancy in 25% of the cases, and after a preterm or a term normal pregnancy in another 25%. So in the first instance, that is molar pregnancy, we are aware that there is a possibility of GTN, whereas we will be caught unawares after an abortion or after an ectopic pregnancy or after a normal delivery. So these are the cases which will be missed, and these are the cases which will definitely be tougher challenges to manage. What are the clinical presentations when it turns neoplastic or GTN? There will be abnormal vaginal bleeding, either after a HMOL evacuation or after an abortion or after a normal delivery. In fact, now we have made it a dictum in Manipal, if a person comes after anything, whether after a normal delivery, after an abortion, after a HMOL evacuation, or whenever it is, if there is an abnormal uterine bleeding, we have made it a practice to do a beta HCG. It may be anything else, unless there is an obvious fibroid or other things. We have made a habit to do beta HCG because it could still be a case of GTN, and we have definitely been benefited by that practice. Bleeding from metastatic sites is another clinical presentation. There could be hemoptysis if there are lung metastasis. There could be headache. There could be liver bleeding, giving rise to epigastric pain and things like that. Pulmonary symptoms, cough, chronic cough is one of the problems with pulmonary metastasis. Neurological signs from spine and brain metastasis. Localizing signs may be seen, and for all you know, it may be a case of GTN. GTN should be considered in all patients with unusual presentations and if the serum beta HCG is elevated. So a neurologist may be in for a surprise when he does serum beta HCG. It is very obvious for an obstetrician to think of these things, especially GTN and ectopic pregnancy, whereas in medicine and physicians, they always miss it. GTN, FIGO criteria to diagnose as you do the follow-up. When the plateau of HCG lasts for 4 measurements over a period of 3 weeks or longer, that means, let's say, day 1, day 7, day 14, and day 21. So 4 consecutive measurements over a period of 3 weeks, something like this. Suppose beta HCG has come down initially, but then it plateaus over 4 measurements. That is one criteria. The other criteria is when there is a rise in HCG for 3 measurements over at least a period of 2 weeks or more, that means 1, 7, and day 14. Something like this. As you can see here, initially it fell down, but then it was steadily increasing 3 over 3 measurements spread by 2 weeks. Or let's say it came down nicely for 6 months, it was normal, and then there was an increase. So this is really a tragedy. It is something like a bolt from the blue. So here it is. Initially, it just came down nicely, less than 10 or less than maybe 5, and you thought we got rid of it, but suddenly there has been an increase after 6 months. So that is also a case of GTN. So we have 3 varieties. One is beta HCG plateauing over 4 measurements, or beta HCG increasing over 3 measurements, or beta HCG came down but increased after 6 months. These are the 3 cases of definite GTN. Or if you have sent the material, evacuated material for pathology, which is not mandatory, but if you have sent it, and if the histopathology says that it is choriocarcinoma, then obviously it is GTN. So this is the FIGO criteria. Now, what are the diagnostic evaluations you must do when you suspect GTN? Obviously, beta HCG you have to do, and not only beta HCG, all components of HCG, CHCGs and choke HCGs, and every component of HCG should be done, and that will help us in scoring system, which I'm going to talk shortly. Ultrasound is a must, both pelvic as well as abdominal ultrasound, to see whether the GTN is localized, that is invasive mole or placenta-site trophoblastic tumor or ETT, or whether it has gone beyond uterus, either to adnexa or to pelvic organs or to abdominal organs like liver, kidney, spleen, and everywhere. If you suspect metastasis for any reason due to patient symptoms like coughing, headache, and other things, then lungs, 80% of the time there can be metastasis. It can be easily made out by chest X-ray, the famous cannonball appearance, and lung CT also can be done. The only good thing about lung metastasis is that the risk score does not increase, and this does not call for combination chemotherapy. Vaginal metastasis is common 20% of the time. It can be easily made out by speculum examination. The commonest metastasis we see is a suburethral nodule, but what I want to highlight, what I want to caution is, please don't touch it. Don't attempt removal of this suburethral nodule. You'll be in for a heavy bleeding which cannot be controlled at all. Similarly, on speculum examination, you can see a cervical choriocarcinoma. Again, this should not be disturbed. Regress on its own when you give chemotherapy. So liver metastasis is common in 10% of the cases. You can do a CT abdomen and liver function test. Brain mets can be made out by CT or MRI brain. And of course, all other investigations like CBC, RFT should be done both pre-chemotherapy as well as post-chemotherapy. The prognosis of GTN depends mainly not only on anatomic extent, but also on other factors. This is the difference between the choriocarcinoma and other carcinomas. When we talk about uterine carcinoma and cervical carcinoma, we don't talk about other factors other than anatomic extent. That's why you see only staging of those cancers. Whereas in GTN, you have not only staging, but also risk scoring. So what are the other factors? Age matters. Antecedent pregnancy and interval from that antecedent pregnancy matters. Serum beta HCG values, number, site and size of metastasis, prior chemotherapy, and both staging and risk scoring is very important. So staging and risk scoring has been there for a long time. The first one was by UICC, under which I went for the fellowship, International Union for Cancer. That is in 1967. Thereafter, Bagshaw, the Professor Bagshaw scoring, 1976. FIGO staging, 1982, revised in 1992 and 2000. And WHO also gave a scoring based on Bagshaw scoring. They modified the Bagshaw scoring. They removed just the blood group and type. Bagshaw scoring had blood group and type also. And recently, that recently means 18 years ago now, that's the one which is holding still. FIGO adopted both its own staging and WHO scoring system, and it is now holding as a combined staging and scoring. So what is this FIGO staging? Very simple. Stage 1 is localized to uterus. Stage 2 is to pelvis and adnexa only. It is within the pelvis. Stage 3 gone beyond pelvis to pulmonary metastasis, and stage 4 is distant. It could be liver, brain, kidney, GI tract, and spleen. So one may get confused. Pulmonary is also a distant one, but pulmonary is staged under 3 because it's not that serious, whereas other ones are very serious. WHO scoring, which was a modified Bagshaw scoring, now adopted by FIGO in 2002, which has got 0, 1, 2, and 4 based on the risk factors. The maximum score is 25. If the age is less than 40, 0, more than 1, thereafter, there is no more score. Antecedent pregnancy, if it was molar pregnancy, it is 0 because you expect, whereas it becomes 1 if it was after abortion, and it is 2 if it is after normal term pregnancy, because you don't expect her to get GTN. That's where the score increases. Interval from index pregnancy. Suppose if it occurs within 4 months when the surveillance is going on, so you are not caught by surprise, so it is 0. Whereas if it is 4 to 7 months, 1, 7 to 13 months is 2, and beyond 13 months, that means after 1 year, you have celebrated child's birthday and suddenly you will get GTN, is definitely not expected. So you get 4 marks. Pre-treatment HCG, more than 10 to the power of 5 gets the highest marks. Largest tumor size, more than 5 centimeters, is maximum 2 marks. Site of metastasis, as I said earlier, lung metastasis gets 0 score. That's why probably, even though it is a distant metastasis, FIGO has staged it under 3. Whereas spleen and kidney, 1, GIT is 2, liver and brain is 4. Probably liver is a very important organ, that's why, and of course, brain is very distant and it can cause severe morbidity. Number of metastasis matters. When it is more than 8, maximum score is given. Previous failed chemotherapy, obviously, when it is failed, single drug failure is 2, multiple drug failure is 4 marks. So as I said, altogether is 25 marks, but it is considered low risk when the total score is less than 6, and high risk when the total score is more than 7. I'll give a couple of examples for combined FIGO staging and scoring. Low stage, low score. Here is a case, 42-year-old, 9 weeks post-evacuation, ultrasound shows adnexa is free, there is a mass in the uterus, all right, and HCG is just 10,000 and no metastasis at all. So how do we score that? Age 42, she gets 1 mark. Antecedent pregnancy was a molar pregnancy, so 0 marks. But interval 4 to 7 weeks, that means 1 mark again. Post-treatment HCG is just 10,000, so 1 mark. Largest tumor size is less than 3 centimeters only in the uterus, 0 marks. No metastasis, so 0 marks. Number of metastasis, 0 marks, and everything else is 0. So what you get here is a low score of just 4, or less than 4. Whereas a high stage, high score, 41-year-old, 7 months post-delivery, mass of 4 centimeters, HCG 100,000, 2 liver mets. So how do we score that? More than 40 years, 1 mark. Antecedent pregnancy, term pregnancy, 2 marks. Interval 4 to 7 months is 1 mark. And pre-treatment HCG is more than 10 to the power of 5. Tumor size 3 to 5 centimeters, so 1 mark again. Site of metastasis, liver mets are seen, and number of mets is 1 to 4. Total score will be 14. So it is a high score and high stage. So what is the treatment? Stage 1, 2, and 3. 3 is liver mets, 3 is lung mets. As I said, it gets 0 marks, so nothing to worry. Basically, we are looking at stage 1 and 2 in a way, and score is low risk, less than 6. Single agent therapy is all that is required. Whereas if the same stage has got high risk, then you need a combination therapy. Maybe it is stage 2, but you will see the number of mets more, or the size is more, or antecedent pregnancy was term pregnancy. Stage may be low, but risk may be high. So that is the importance of combining stage as well as risk scoring. I hope I'm very clear. So this is the only cancer where just stage is not enough, risk is also important. High risk in the same stage calls for combination therapy, whereas low risk in the same stage calls for single agent chemotherapy. I hope I'm very, very clear in this. Whereas stage 4, obviously you can't have, when it is stage 4, when liver mets are there, it can't be low risk. So there is only one, that is stage 4 is obviously high risk, so combination chemotherapy is all that is needed. So now I come to what is this single agent chemotherapy. There are many single agents. Methotrexate, folinic acid is not an anti-cancer drug, it is just a rescue drug. Methotrexate is a single agent used. Actinomycin D is another single agent used. Then etoposide you can use as a single agent, 5-fluorouracil. And if there is inadequate response, you can alternate the agents. A recent Cochrane review, 2016, shows that actinomycin D is superior to methotrexate. But the most popular single agent chemotherapy even today is methotrexate. Now, how is it given? This was popularly called in Charing Cross Hospital, London as 1 week on, 1 week off, or Monday to Monday regime. And the patients were straight away admitted for 3 weeks. That means first week you give chemotherapy, second week off to see the complications of the patient, and third week you give second course, and then probably you can discharge the patient home and she can come alternate weeks. So what is this 1 week on, 1 week off? As you can see, the first week, and it is called Monday to Monday, I said, day 1, 3, 5, 7, you give methotrexate, 1 milligram per kg IM. Day 2, 4, 6, and 8, alternate days, you give folinic acid rescue. Can you see here, you started on a Monday, you end on a Monday. And that is the first week. That Monday, next Monday to third Monday, nothing, 1 week off. So like this, you keep on giving 1 week on, 1 week off, 1 week on, 1 week off. How long? I will keep it as suspense. I will tell you a little later. Now, combination chemotherapy, IMACO. Earlier, we had Shamoco regime of Bagshaw. It has now been changed to IMACO, which is very popular. Etoposide, methotrexate, actinomycin D, cyclophosphamide, and oncovin, or also called vincristine. The other combination therapies can be EP-EMA. Instead of EMA-CO, EMA-EP, wherein you have added cisplatin. There are other combinations also. I will talk about that later. Now, this regime was popularly called 1 week EMA, next week CO. 3rd week EMA, 4th week CO. 5th week EMA, 6th week CO. So 1 week EMA, 1 week CO is the regime here. As you can see here, it is also Monday to Monday only. But here, instead of saying 1 week on, 1 week off, you say 1 week EMA, Monday, etoposide, methotrexate, actinomycin. Tuesday, you give etoposide and actinomycin, you skip methotrexate. Instead of that, you give folinic acid as a rescue. Day 8, that is next Monday, you give cyclophosphamide and oncovin, CO. Can you see here clearly? 1 week EMA, 2nd week CO. Again, day 15, the 3rd Monday, you start with again EMA and CO. So it's very easy to remember. 1 week EMA, 1 week CO, whereas single agent is 1 week on, 1 week off. Both are Monday to Monday. Now there is something called salvage therapies. When the treatment has not been successful, she has got recurrence, she has got resistance or whatever, then you can use EP-EMA. As I said, P stands for platinum. So here it is etoposide, cisplatin, again etoposide, methotrexate, and actinomycin D. EMA is common. Instead of CO, you give EP. TPT, paclitaxel, is another very popular drug. We all gynecologists know that, used in ovarian cancer. Cisplatin is another very, very, very famous drug that we all know. TP and paclitaxel, etoposide. Etoposide somehow is a very good drug for GTN. And then you have BEP. We all are familiar with BEP also. It is used in germ cell tumors, or it is a very popular drug for younger ovarian malignancies, germ cell malignancies. Bleomycin, etoposide, and cisplatin. You can also use BEM, M for methotrexate, which is again a most popular drug for GTN. High-dose chemotherapy with autologous bone marrow or stem cell transplant also have been tried, and immunotherapy using this drug also has been tried. Cerebral metastasis is managed by giving intrathecal methotrexate, or you can combine chemotherapy with concurrent whole brain radiation. Monitoring is very, very important, not only after evacuation of mole, it is also important during chemotherapy. It is done to see the response to drugs by HCG regression curve. Here also you expect a 10-fold decrease. It is also done to see the toxicity. What do? You do CBP, renal function test, liver function test before each course. Now I come to the revealing of the suspense. I told you how many courses of chemotherapy. Chemotherapy is continued until HCG titer is normal. Postponement of chemotherapy is admissible if there is severe toxicity, but you can resume it a little later. If remission occurs, what do you mean by remission? 3 consecutive weekly normal HCG is called remission. If it is a low risk, at least 1 more course beyond the remission. That means the beta HCGs come down to normal consecutive 3 weeks. Even then you give 1 more week in a low risk patient. In a high risk patient, you give 3 further courses beyond remission. I hope I am very clear here. You keep on giving 1 week on, 1 week off, 1 week on, 1 week off, till beta HCG comes to normal for 3 consecutive weeks, and thereafter you give 1 more. Whereas in high risk patient, 1 week EMA, 1 week CO, 1 week EMA, 1 week CO, keep on giving for 3 more courses after beta HCG comes down to normal. Now you may ask me, why this 3 more courses or 1 more course? Because of the microscopic or micro levels of beta HCG, which are produced by microscopic lesions that may not be coming into the bloodstream, and it may not be very obvious, but that can still grow later. That's the reason we give one more course in spite of beta HCG being normal for 3 consecutive weeks. That means beta HCG has achieved remission. Follow-up after chemotherapy is also very important, something like follow-up after evacuation. That is stage 1 to 3. You can do weekly until 3 normal values. It's almost the same as post-evacuation follow-up. Monthly until normal values for 12 months. It is something like, again, post-molar evacuation, up to 1 year follow-up, basically, it means. Whereas stage 4, where you have given combination chemotherapy, weekly until 3 normal values, that's the same, but monthly until normal values for 24 months. So if it is a high-risk patient, 24 months follow-up is required, and she should not conceive for 2 years in a high-risk patient. Contraception to be used can be OCP, can be depot preparations, or barrier contraceptives. What are the cure rates? In a non-metastatic, it is 100%. This is a success story. We always are proud of our chemotherapy for GTN. Metastatic but low risk is also 100%. It's only metastatic with high risk, it drops down to 70%. What are the small but significant increase in secondary tumors like AML, colonic cancer, and breast cancer, and early onset of menopause, probably because it destroys the follicles of the ovary. Fertility outcome somehow is not adversely affected in the pregnancy if she conceives after 6 months of follow-up, or after 1 year of follow-up in the low-risk patients, or after 2 years of follow-up in the high-risk patients. If she becomes pregnant, there are no adverse pregnancy outcomes because all these drugs would have been washed out in the body, from the body. In subsequent pregnancies, however, you must do early ultrasound, and you must send placenta and its products of conception for histopathology after delivery. And serum beta HCG levels you must do for at least 6 weeks after completion of the pregnancy or after delivery. And finally, I come to what is the role of surgery. As I said earlier, the primary surgery is done only to control complications, that is severe bleeding, perforations, or rupture or lacerations of the uterus. Hysterectomy for uncontrolled bleeding. Laparotomy is basically to stop bleeding from liver, GI, kidney, and spleen. Whereas the PSTT, placental-site trophoblastic tumor, and ETT, both of them are chemo-resistant, and that's why they require surgery, and surgery is hysterectomy. The secondary indications are if there is drug resistance to the disease, or if you want to remove some isolated metastasis, then you may do a surgery. The role of radiotherapy, as I already mentioned, it is usually combined with chemotherapy for brain metastasis. A slide about PSTT and ETT is that they are rare, luckily, but they can be there. We had a couple of cases of them. They represent neoplastic transformation of intermediate trophoblastic cells. And the most difficult part is the HCGs will be low. Patient will come with abnormal uterine bleeding, which is not responding to anything. Then you would probably suspect PSTT and ETT. And this can be after a normal pregnancy also. Primary treatment is surgery because, as I said, they are chemo-resistant. Having said that, you can still give EP-EMA or TETP in advanced stages, where in spite of surgery, patient is having problems. So sum and substance of what is said is that GTD is common in the east and extremes of age. It has got androgenesis, that means the CHM is all paternal. A anuclear egg is fertilized by either homologous sperms or a single sperm which duplicates, whereas partial headed form mole is a nucleated egg fertilized by 2 different sperms. That's why they will have both maternal as well as paternal contribution. Early diagnosis is important, and it is possible nowadays with ultrasound. You have to still do HCG to know the initial values. Immediate evacuation without wasting time is the treatment for H moles. And a strict follow-up using HCG is very important. Weekly till it comes down. By 8 weeks, it comes down, and thereafter monthly for 6 months and 2 monthly for another 6 months. Up to 20% can turn malignant, more so complete head form mole. That is to be very, very important to remember. But also important to remember, it can happen after a normal delivery also. GTN is suspected with plateauing or increase of HCG or an increase after 6 months of remission during a follow-up. Combined FIGO staging and risk scoring is very important, not just the staging, but risk scoring is equally important. Stage may be low, but it can be high risk. Low risk means less than 6, high risk means more than 7 out of the 25-point scoring system, which consists of age, the antecedent pregnancy, and the type of the interval from the pregnancy, beta HCG levels, metastasis, the place of metastasis, number of metastasis, size of metastasis, and previous chemotherapy. These are some of the risk factors. Highly chemosensitive tumor. GTN is a highly chemosensitive tumor with 100% cure rates in low risk patients. Low risk, you can give single agent, which is mostly methotrexate, Monday to Monday regime, 1 week on, 1 week off, for one more course after remission. Remission means 3 consecutive normal beta HCG. High risk requires combination chemotherapy, mostly IMACO regime. Here it is 1 week EMA, another week CO. Continue for 3 more courses after remission. It is Monday to Monday, not Monday to Sunday. 1 week on, 1 week off, 1 more course in low and 3 more courses in high risk after normal HCG. PSTT and ETT require they are chemo resistant, so they require surgery. Radiotherapy is for brain metastasis, hysterectomy only for complications, that too in an elderly patient who has completed family. Thank you very much for your patient listening. I'll be happy to answer the questions.
Thank you, sir. Thank you so much for this wonderful session, sir. Before starting the question and answer, I would like to welcome our chairperson, Dr. Anjali Kannada ma'am. She has joined us, and she's MBBS MD FICOG. She is professor and head Department of OG PMCH Bhopal. She is a national corresponding editor, Jogi, from 2014 to 2017. She is a life member, Foxy Bhopal, and life member of IMS Bhopal. She's the recipient of the famous Dr. Jagdishwari Mishra Best Poster Presentation Award for 3 consecutive years, YCOG 2014 Patna, 2013 Mumbai, and 2012 Varanasi. She has special interest in high-risk pregnancy, medical education. She is president of Bhopal Obs and Gynae Society from the year 2021 to 22. That is the present year. Welcome, ma'am, and thank you so much for taking out time from a busy schedule for this session. Thank you, ma'am.
Thank you so much, Ratlam Society, for having me over. And sorry, I could not join in time because of some issues in the department. But it was wonderful to listen to Dr. Pai. We were very fortunate to have him over in Bhopal Society just with some other topic couple of days back. Sir, you are master teacher and you make things so clear, so clear. Really, a big thank you for letting us know so many new things of teaching. Wonderful presentation. Thank you so much.
Thank you.
Thank you, ma'am.
Thank you, Ratlam Society, for
Thank you, ma'am.
letting me be on your society forum. Thank you so much.
Honor for us, ma'am. Thank you for coming.
Now, sir, we would like to go to question and answer sessions now, sir. The first question is by Dr. Preeti Mehta. She asks us, please tell about role of methotrexate in complete mole and partial mole.
Yeah, as I said, the treatment for complete mole and partial mole is evacuation only, right? So
Yes,
you have to do the evacuation and follow. There is no role for prophylactic chemotherapy unless during follow-up you think that there is plateauing or there is increase or there is remission by increase, or if the histopathology by chance shows any GTN. Otherwise, there is no need to give methotrexate for either complete mole or
Okay, sir. Thank you, sir. Thank you so much, sir. Sir, I had a doubt, sir. Supposedly they are twins, sir, and we find like one twin is having
yeah, very good
symptoms
question.
of
We had a
GTN.
case in Manipal.
Yes, sir.
So we took the pregnancy till 34, 36 weeks and we delivered her. Nothing will happen. Don't attempt curettage or evacuation of the other sac. So
Yes, sir.
nothing will happen. And
Okay, sir.
we have published that paper also. In fact,
Okay,
I
sir.
forgot to add that slide here. So nothing will happen. Just
Okay,
follow up
sir.
this.
Just follow up, sir. Whether it is partial mole or complete mole, sir.
Yes,
In
yes,
both the cases, sir.
yes, yes.
Thank you, sir.
In fact,
Thank
we
you
had a
so much.
complete mole and a normal pregnancy, normal baby.
Okay, sir. And sir, one more doubt, sir, like the other twin, which is a normal twin, sir. So how can we actually make sure that the other twin is perfectly fine? He or she is not having any malformations or any aneuploidy or something.
No, you have to do ultrasound of the other twin properly, and you can do all the other tests what we do normally
Yes, sir.
aneuploidy screening.
Okay, sir.
There is
Nothing
no
special,
danger.
sir. Thank you, sir. Thank you so much, sir. So, I think we are out for questions, sir. Anybody who wants to ask sir anything, sir? So everyone is like, it was a concept clearing session. Thank you, Pai, sir. This is from Yashodhara Gaur, ma'am. Then everyone is wonderful class, as always, wonderful talks, sir.
Thank you,
So
thank you,
real nice session, sir. Thank you so much, sir.
thank you very much for the opportunity, and it's always my pleasure.
Thank you, sir, for excellent elaborative talk.
Thank you,
I
ma'am.
would
Thank you, Manisha, ma'am.
I would request Dr. Anjali ma'am to please sum up the today's session with a concluding remark. Ma'am, Anjali ma'am?
Am I audible?
Yes, ma'am. Perfectly, ma'am.
Okay. Summing up on sir's session is going to be a difficult task for me. He has made it so clear, actually. His take-home messages were perfect, telling that no termination is needed if you have beta HCG levels as normal, telling that OCP can be given to the patient, letting us know that how exactly evacuation can be done, no need of using mechanical dilators because the cervix is usually very soft. He was very clear about the GTN scoring, and absolutely wonderful with the chemotherapy. So it was a wonderful talk, and I'm sure that is why he's so popular with his PG students and his colleagues. It is wonderful to learn so many new things from you, sir. Thank you.
Thank you, ma'am. It's my pleasure.
Thank you,
Really
ma'am.
feel blessed to have all of your goodwill and love.
Yes, sir. Thank you, sir. Thank you so much, sir. I would like, on behalf of Ratlam Ops and Gynae Society, I would like to thank you for the time, pain you have taken to join us. I would like to thank our chairperson, Dr. Anjali ma'am. And sir, it was really a great webinar and would definitely help us in our clinical practice. I would like to thank our ROGS president, Dr. Manisha Maheshwari ma'am, secretary, Dr. Neha Shroff ma'am, for allowing us this wonderful session. I would also like to thank all our participants who made this session a successful event. Last but not the least, I would like to thank Pharmacent for arranging such a wonderful session. Thank you, sir. Thank you so much.
Thank you, Dr. Shika. Thank you, ma'am, Manisha, ma'am, and Neha, and Dr. Anjali, ma'am. Thank you.
Thank you, sir. Thank you, Manisha, ma'am.
Thank you, sir.
Thank you, Neha, madam. Bye-bye. See you sometime soon.
Yeah.
Bye.
I'll log out.
Yes, sir.
Thank you, sir.
Bye, ma'am. Bye, sir.
Bye-bye. Bye-bye, everyone.